Welcome. I'm Professor Ian Hickey with my great colleague, Dr. Elizabeth Scott, in Seminar 4 of our Brain and Mind Centre Youth Model Seminar. This one's all about care, about how we move from assessment, multidimensional tracking, measurement-based care, to actually choosing which treatments for which person. That more personalised, or if you prefer the lingo of the day, precision-based approach to care. The next slide. Just at the start, as always, we'd like to recognise the traditional people on the lands of which we meet, which for Brain and Mind Centre at Camperdown are the Gadigal people of the Eora Nation, and the recognition of their centuries of experience working as a community to solve mental health problems, and of those who have direct personal experiences of mental health issues. Next slide. Okay. So this is Seminar 4, how to get from assessment, tracking, some new clinical concepts that we brought in, clinical stage and pathophysiology, to actually the fourth bit, choosing best care first time, or right care first time. Not second time, third time, fourth time as we go, but actually, if we can, making the best treatment decisions on the first occasion. Next slide. Okay, so just to recap some critical concepts here. When we talk about best care, we're trying to take into account not a simple, narrow diagnostic concept, which is traditionally driven. I mean, many people believe in medicine, you get the diagnosis, then you choose the treatment that's optimal for that situation. Now, of course, in the rest of medicine, that is becoming increasingly untrue. In many areas of cancer, in many areas of infection, in many areas of other immunological function, you're trying to choose the treatment that is most likely to work for that particular cancer in that particular person, or that particular intervention that is most likely to be relevant to where they are, relevant to their stage of illness or their other complexity. You know, I must say the original issue of comorbidity had to do with not simply saying what overlapping psychiatric disorders did you have, but if you had cardiovascular disease, for example, you received certain treatments, but you also had diabetes, then it really mattered to know about the diabetes while treating the heart disease. So this issue of complexity, comorbidity, is one that's important. For us, there are 5 key areas. The one we'll return to continuously: social and occupational functioning. Do, as a consequence of the treatments we provide, in a total sense, a young person get their life back? The extent to which we reduce self-harm and suicidal thoughts. The extent to which we deal with other comorbidities, alcohol and substance misuse. One that we dealt with a lot in the last seminar, the extent to which physical health comorbidity is addressed, while we actually track the development of the particular mental health problem that seems to be central to the particular issue, taking into account not only what type of disorder, but the stage of illness that a person has. Next slide. So we see people as being on developmental paths and on trajectories, moving from less specific to more specific syndromes over time, seeing different constellations of symptoms rather than simple diagnostic categories, and trying to intervene as much as possible earlier on. Of course, when you come to choosing treatments and you're not that confident about what it is exactly the person has, you might well panic and not want to actually provide care. Liz, should we panic and provide no care?
No, we're just going to take it very calmly and do proper multidimensional assessments.
And then choose care options.
And choose care options for the syndrome the young person is presenting with, not for the diagnostic category that we think we can wedge them into.
And you're allowed to have more than one. You can have more than one problem.
Yep.
As some of the young people you'll see in some of the seminars discuss, and Jordan, who will appear in one of our seminars in the future, you know, if you knew his parents and his grandparents and his aunts and uncles and the range of syndromes that they had all had, to think that he's just got one syndrome or inherited one problem might be to entirely miss the point. And now the reality is, for a lot of young people we see, particularly those with early onset particular issues, they have complex syndromes in addition to complex physical health problems, challenging environments, and may already, of course, have developed other physical health problems or concurrent alcohol and drug use. So there is uncertainty. There's real uncertainty. The earlier you intervene, the less clear cut it is. But over time, trying to work out from an n=1 point of view, what set of interventions most assist this person to get well now and protect them in the future is really the clinical goal. Next slide. So what we suggested during the previous seminar is the need to make sure that as you do this, increasingly, you don't just off the cuff choose one thing one week and something else another week. You try to use more standardized assessments. The greater use of standardized measures for clinical markers, the greater use of objective measures for things like metabolic markers or for circadian markers or for other hormonal function, and the extent to which we try and track that over time. For syndromes that get more complicated, a greater willingness to use more objective measures, more modern brain scanning, like neuropsychological, more complex immune, and other measurements to gain a better idea, but also with a repeated measures focus. You're probably not going to do those things once. You're going to try and track over time what is happening and track the relationships between those things over time as treatment or as the syndromes themselves become more complex over time. Next slide. So the focus today is really on treatment selection. Okay, when things get hard, lots of assessment, lots of discussion, but at some point in partnership with a young person and their family, you're going to have to make a decision about actually what do we do. And it's an early intervention decision. It's often before the person clearly has the favourite type thing on which to choose, which is really complicated because most of our clinical guidelines come from areas of working with adults in midlife who've already got those things and a lot of comorbidity and a lot of difficulties, but at least some confidence about the syndrome they've finally got. The application of those guidelines back to earlier areas in which the whole database is less clear-cut is really challenging. And we accept in that area there's a great deal more work to actually be done. So Liz, we also enter people into studies, track what happens. How important it is to keep building an evidence base here.
So obviously in areas where there is limited evidence, it's really important to be able to track people over time, to understand what are the predictors for treatment outcomes and of recovery, and what are the predictors of poor response. So enrolling people into studies, and I have to say in our youth cohorts where we provide treatment and ongoing care, the uptake of the young people into research has been incredibly high. They actually want to participate. They want to know what is not only going to help them, but what might help other people in the same situation. And like in cancer, the goal is to provide better care by closer monitoring of the key outcomes to these cohorts of young people.
So it's an important thing here. In our world, we get rung by people all the time saying, my young person's in trouble, where is the best place to go to get care? And we often say somewhere like the places we work where there's more assessment, there's more standardization, there's access to more fancy and elaborate equipment, there's more commitment to things. Most of what we're trying to do though is get that out of our specialist clinics and into regular care, hence the point of these education seminars, but also the use of new technologies to assist us to do that. In the post-COVID-19 world, people are using technologies like we are today, but actually you can use those in care. So we've got three big things, all of which are assisted by technology and all of which matter in these particular areas of tracking over time when we're thinking about what treatment. And they're so not about which diagnosis. They're about multidimensional assessment and tracking over time. And frankly, if you don't have smart systems to help you do that, no one can keep track of multiple things in their head against all those dimensions over time and actually understand what's going on and share it. Share that data with young people and their families continuously. That's critical. The second is clinical staging. We're always trying to do things at earlier stages that are simpler, potentially less toxic, potentially achieve the result, but they've got to work. And with clinical staging says treat now and prevent progression if we can, the dual goal. And the third is trying to say, look, there are these broad developmental things. Not everything is the same. There are those who've got neurodevelopmental and brain development problems, more likely to end up with psychotic type disorders. There are those who've got circadian disruptions, attentional system disruptions, rhythms problems, more likely to end up in the bipolar atypical spectrum. And there are those that have the most common, of course, anxious temperaments that become anxious depressive temperaments that are having difficulty coping with change in their life always on an ongoing basis. And have ideas about that because the treatment selection in each of those areas is somewhat different over time. Next slide.
For me, finding the right treatment was quite a challenge. We started off seeing a psychiatrist who, over the course of the couple of months that I was seeing her, must have prescribed a good 10 different medications that are commonly used for bipolar, and none of them seemed to work. So there was a lot of experimentation going on before I finally got to see Liz after a few months. And from there, I managed to get myself admitted into youth space, and that's really where the right treatment started, a good 3-4 months after we realized that there was really a mental health issue for me.
Next slide. So Liz, this raises the really complicated issue, okay? We're gonna hear a lot of stories where you've saved people, because that's kind of like the good stories, obviously. But often for everyone, they are on an N=1 journey. We're not saying in Josh's story that necessarily the psychiatrist he first saw, the system he came in through, did the wrong thing. It's just that he was very complicated and developed very rapidly from a fairly non-specific or an agitated situation to developing a more frank bipolar-like, although in that situation itself, somewhat more atypical. So do you want to just kind of comment on the journey? One could always look really smart in retrospect, but going forward, you know, we are likely to be as wrong as anyone else.
Yes.
But tracking people, so just kind of how you cope with that.
So first of all, I'd like to say that rather than people saying, you know, I saw Liz and then everything was great, it'd be great if people said, I saw my psychiatrist or my psychologist, and after that, everything, you know, was on track. So that's our goal, to be able to provide the kind of treatments that we can, that we are able to do, and to make sure that they become, they come into kind of standardized care. And that means this kind of idea about personalized care, which is not genetics. It's not about what gene you have and waiting until we can identify the gene or how you metabolize a particular antidepressant. It really is understanding all of the factors associated with that young person's presentation. So for Josh, he had some really important medical comorbidity, which was probably driving his care and making him not less resistant to response to traditional treatments for bipolar disorder. And it was not until we became aware of that and factored that into his care and really focused on his sleep-wake cycle as being the really critical thing and trying to reduce some of the other drivers for that, that we really got his illness under control. And now, you know, 12 months later, almost 12 months later, he's in a really good place, finished school, about to start university. But I will just say, I saw a family recently with a young person, 13, who's been unwell for quite a while now, has been in 2 different hospital systems, diagnosed with anxiety and then with an eating disorder and now with a severe depressive disorder, has got actually good care in each different part of the system, but no coordinated care for the syndrome that the young person has. And the family said to me, couldn't somebody deal with this holistically? Isn't there somebody that could actually deal with the problem that this young person has? That the most recent thing was to say, because of change in cognition and social cognition, well, this young person must have an autism spectrum disorder, which they didn't have a year ago or 2 years ago. So, but trying to fit a diagnostic category, as opposed to doing a holistic assessment to try and understand the syndrome that the young person has, the track that they're on, and provide interventions that will help to treat and modify the course of illness, which is becoming progressively worse over time, despite good care for the individual problems.
So to take that point, I mean, the assessment's been done, but often systems just respond to one thing.
Yes.
That girl, let's just call her Beth, for a chance. You know, Beth needed different kinds of interventions at different points, but nobody wanted to take responsibility for the total care of that particular issue, nor the continuity of care. So go back to the Josh situation where you started treatment. We could be as wrong as anybody in the first instance, but the measurement-based care option, what's shown in the cycle here, is if you're continuously tracking what is happening holistically, using all those frameworks, you can rapidly see, in a Josh's situation, if it doesn't get better or if it deteriorates, what you're doing is not sufficient, and actually know that the initial choices were not right for his situation. For Beth's situation, just those individual elements at one particular point, and trying to change the diagnosis then to fit the outcome. Okay, now she's got social cognition problems, so let's pretend she had autism in the first place when she didn't have that to start with. Doesn't really help. You know, actually, it's distinct from saying she's got whatever she's got, and it's an early stage, she's relatively young, it's evolving, it's complex, she's facing the developmental challenges of being a young teenager with some evolving things, and not surprisingly, for a young girl, there's eating disorder elements, there's body image elements, there's anxiety elements, there's social cognitive elements. They're not 20 different disorders. Beth's got whatever Beth's got. That's the personalised bit. What her family wants to know is, are any of the healthcare bits coordinated? Does anyone behave like a physician who puts this together? does anyone actually track with us what is happening to plan the next step? And that's really where the measurement-based care option, tracking it, you know, and that isn't just seeing people occasionally saying, oh, what's happened in the last 3 months? What's happened now? Or why are you here today? What is the continuity of that over time? So getting it clear, each person is an individual, the personalised aspect, and then tracking their improvement over time. If they get better, great. First treatment, excellent. But if they don't get better or they deteriorate, what happens next? That's really the challenge clinically. Next slide. So to take a lot of the stuff that we discussed in general, right down to the specific level, this is a diagram that we use quite often with people to say, where are you, and with their families, where are you and what are we trying to do now? Are you over on the left? You're relatively early, like in stage 1A disorders. You haven't fallen that far, but enough to get you into care. We're going to get the ladders. The treatments are the ladders to get out of that particular hole, which at this stage is not that deep. Now, hopefully when it's not that deep, really the issue of using a whole lot of psychological behavioural therapies is going to be the basis of most intervention. And if that's enough to get the young person out of the hole, great, because not only have they got those skills to get out of the hole, they may well be able to use those same skills in addition to others to then prevent any further recurrence or falling into a deeper hole. Now, even when you do that, a certain proportion of people, and in our work about 5% of the ones who fall out of the stage 1A and get better within a year are going to fall into the stage 1B group, a deeper hole, a longer hole, and harder to get out of, where actually the combination of not just those psychological therapies and monitoring, but actually more specific psychological or social interventions and the potential for more specific pharmacological interventions really come into play. Now, of course, whenever we introduce pharmacotherapy into these situations, the active tracking of the response to pharmacotherapy, and particularly the active tracking of adverse events in the initial phase of that therapy, becomes critical. But whatever the combination that gets people out, even more important then, what do you do again to prevent that situation? And how actively do you actually pursue those issues? So we are constantly playing up. Now, unfortunately, many young people we see, a bit like Josh, are already in deep trouble by the time they get to us. And to see the stick figure there looking rather demoralised, often they're demoralised, and often their parents, frankly, are distressed and or angry with the inadequate care and the dislocation of care, just like in the Beth case you were describing. They can't really figure out why no one's interested in what previously happened. And they say, I'm only going to do the bit for the next 2 minutes. I'm not going to plan the next 5 years with you. I'm not going to take care of you. We're not going to be continuity here. We're going to either admit you to hospital because you're unsafe, or we're going to discharge you from hospital because you've been here long enough. But we're not going to plan the rest. You know, this idea of seeing a young person across all these phases where the constant goal is twofold. Get out of the hole. And sometimes to get out of the hole requires more extensive acute therapy and more experimentation when it's not working. And then following that up with how to prevent recovery, how to maximize recovery and prevent relapse or remission and achieve remission longer term so that people do return. And I think one of the things to emphasize here is, having spent the most time with a lot of these people who present really badly, we are not saying that you cannot recover from the stage 2+ disorders. You can see by the ladder there, we're saying you can recover. It's just often more complex. It often requires more time. It often requires combinations of different treatments and different skill sets to get there. But you want to comment, because actually, of course, we've got videos of really good people because they can consent to agree to say they got good care. But, you know, it often is a struggle and takes a long time, even in the best care, to work out what really works for the individual.
Yes, and a lot of the time there is a degree of uncertainty and a degree, you know, a necessity to persist, to actually persist over periods of time and to work with families and explain the steps in assessment and care, but to make sure that they're aware that if things do not go as planned, what the next step will be. And what I say to patients and families all the time is, you're not walking this journey alone. We will be walking it with you. And so it's not as though we are going to send you to knock on somebody else's door if we can help it.
And there are ups and downs. You know, our treatments are not perfect, and we don't know often in the first instance which ladder works for which person. The ladders are not generic. They need to be designed for the person in question by stage, by pathophysiology, by other factors, if there are things that are known, family history of response to lithium, some other particular factor that may be known in a particular area. And by dealing with the complexity, as Liz pointed out in the Josh situation, where there's concurrent physical comorbidity, or there's concurrent drug and alcohol problems, or there's concurrent social chaos, or there's actually often dispute in families as to what need to be done. There's confusion as a result. The number of kids that we see who've been told, where the parents have been told, the kid doesn't really have a problem, it's behavioural, which I particularly love, since what we do observe is behaviour. Yes, these things have behavioural. They're expressed in mood, in cognition, in action on particular things. They're about people's perceptual worlds. What we monitor in the external phenotype is behaviour. What people say when they say it's behavioural, I never quite mean, except it means they're not really ill. You know, in some ways it's under voluntary control and they should get it together. And really, probably you're bad parents for not actually exercising the degree of control that a young person requires during this particular kind of period. One of the things to say about this individual chart too is it can happen at any age. So you can have a young age of onset and quite a developed disorder at a young age, or you can have a relatively later adolescent or young adult onset of particular kind of issues. So the staging shown here is age independent, but for many young people, it is happening during critical periods of development on an ongoing basis. So the Beth example you're using with a young girl with a severe disorder who's only 13, who's just only emerging into adolescence and the early pubertal period, different to a 15, 16-year-old who's moving out in the world in a different way, or an 18, 19-year-old who's left school and is trying to progress in the young adult world. Different kinds of challenges, different kinds of drug exposures, different kinds of social expectations, different goals in terms of recovery, in terms of either reintegration in the family for early adolescents, or certainly for later adolescents and young adults, integration into the wider social world. So if we go to the next slide.
I think what was different about the care I received from Liz was that when me and my parents came to her and they were really, really flustered about what was going on, Liz took the time to listen and understand what we were saying and really considered every option and thought outside of the box as to what could be causing what was going on inside of my brain. And I think also, on top of that, the affiliation that Liz had with Mind Plasticity and with U-Space to be able to work with other health professionals was really incredible for me and helped my recovery be a lot quicker than what it could have been.
So what we're talking about, Josh, is this is the thinking outside the box kind of issue. We've discussed before the problem with dealing with professors of psychiatry who all have their favourite box. Funny how everyone you see fits into the box that you've somehow made famous, and you can see everyone through that kind of lens. What Josh is talking about, of course, is the opposite. The extent to which, for both his parents and himself, in interaction with him, you and the services you're working with were prepared to consider that he didn't necessarily fit inside any box. Why is that so hard?
I mean, the box is a good analogy because we used to think about the brain being a box and being kind of, isolated from the body and isolated from the immune inflammatory system and from, other body systems. Now we are much more aware that that is not the case. It has not, I think, entered into practice. We still, in psychiatry, think about symptoms, descriptive symptoms that fit particular categories in a particular box. And many of the young people that we see, particularly that present very early with very severe syndromes, which Josh had, an extreme, you wouldn't know it now, but he had a very severe illness, do not fit within those categories. And you have to think about what are the other factors that may be influencing the brain, therefore are modifiable. And as he recovered, one of the significant things was the degree of cognitive impairment that he had. It was really, really high. He had no concentration. He was in year 12 at school. So the things that he's talking about are the assistance that he had to get his brain working again, to use cognitive remediation strategies and support with school to maintain his relationship with school and friends and get him through to the end of year 12. So he's in a position to now start university. So those kind of, and I do think, as Josh says, that taking the time to listen, often people have already made up their mind. And in Beth's case, I would say I was guilty of that. Before I even saw Beth, I was thinking, I'm not an eating disorder specialist. I can't deal with this. What I'm thinking about is what's the next referral? Who really would be the best person? And having listened to the family and listened to the story and heard it from the beginning all the way through and listed all the different issues that Beth has, trouble with cognition, social emotional cognition, OCD symptoms, this kind of change in behaviour, severe depression, fatigue, that the eating disorder is not the major issue. Actually, the syndrome that she has does not fit into a box.
Wrong box. No box.
No box.
No box.
It has no box.
No
and
box.
actually, we probably are the appropriate service to actually provide
but
that
she's
kind
young.
of assessment. But she's young.
Right. 13.
Yes.
Right.
Yes.
Chance she's going to get it. Really comprehensive treatment.
Not much.
Another person we know well, this is called Julie, 15. Sorry, we can treat you when you're 16 or 17.
Yeah.
We can't treat you, you're too young.
Yeah.
You know, we have all these other boxes by age and category. You can't have that disorder unless you're older. Or we don't have a treatment system that can respond until you get to a certain kind of other age. Really problematic. The other thing I really like about Josh's story is, you know, his family did want to discuss. They'd read, they were smart. They'd read about immune factors and infective factors and other things other than just the box. You know, in one sense, they knew about the unreliability of psychiatry and the tendency to see things in very narrow terms, behavioural, and not actually get the fact that he might be really sick and maybe sick in a way that our boxes didn't really capture, which made them reluctant to go with conventional treatments. And really all they wanted was a discussion about the broader scope. Within that, within the broader scope discussion, they're quite happy to consider what things conventional psychiatry and mental health would bring, as long as the rest was being considered. To be fair to say, I think others would have said they were very difficult parents. Yeah. The dad was pushy, the mum was upset, you know, like they cared about their teenage son falling apart in the middle of the HSC, and in a very severe way, his behavioural disturbance, his behaviour was extremely disturbed in ways that it had never been before, you know. But the amount of parent blaming that goes on in that is remarkable. As distinct from what he's saying is we listen and we try and listen broadly. So here on this slide, we now address specific interventions on everything except the box. So you see over in the scissors, illness, type, stage, trajectories, see next slide. So we're not going to start with the box, so-called diagnostic and other things that we typically start with. We're going to start with all the other stuff that one needs to be thinking about to deliver multidimensional outcomes of significance. You've made the point with Josh. He was so unwell, but he's gone off to a university now. For those who've seen others in these particular things, Jess, who was so unwell as a teenager, but has now gone through university and higher education.
Doing a master's.
Doing a master's degree. Those who come out the other end. Numero uno, number one is how to get back to social and occupational function. Now, of course, that requires treatment of the syndromal elements. But, unless from the start you're focused on how you're going to get back to school, back to work, back to education, and what other things might be required in that. The Beth example you're using at the moment, in terms of cognitive training, social skills training, whatever else is going on, she may not have the skill set to actually be able to engage in those particular kind of areas at this point. We have other unfortunate stories. I can think of another young man, let's just call him Michael, who had significant, unfortunately, brain injury following a severe overdose, following a particular issue. He could not resume immediately the high level of year 12 that he'd been in before that hypoxic brain damage, etc. A whole lot of other interventions had to happen alongside treating how he ended up in the first place in order to take his recovery in school somewhat slowly, i.e. 2 years of doing the HSC, not one, even though he was a very bright kid to start with, and a progressive cognitive improvement and some limitations in his actual memory function as a consequence of that injury. You know, really responding to the specifics of the situation in order to give him what he really needs, which is to be back in education to finish year 12 in order to progress to where he would have gone, which would have been onto further university level education, given his background, IQ and capability. The second one, which really matters for every parent and for every young person, is actually self-harm, suicidal thoughts and behaviours and attempted suicide. You know, do we actually have the right set of factors in place? The care planning, that's, you know, the safety planning, the sort of mood regulation type things, the DBT type approaches that may be relevant, quite independent of diagnosis, to how to moderate that sense of uncontrollability and emotionality, which often drives impulsive behaviours. Are people getting the right sets of other supports? Are family and others sufficiently engaged to contain those behaviours? And has a lot of thought being given to that and how that continues on? You know, many parents, the Beth situation is a good example recently, rush off to the hospital, hoping the hospital will actually cope. And the hospital decides to admit or not admit for a short period, and suddenly a week later, Nothing's really changed, and they've got the young person again back in the care situation that they were actually in. While we just stop Liz actually answering phones at the same time, we'll just move on to the third one, which is that of alcohol and other substance misuse. Many of the situations that we are dealing with, the person has a concurrent alcohol problem, concurrent cannabis problem, perhaps current stimulant problem, perhaps another drug use set of issues. Is it being attended to? I would include in that the nicotine kind of sets of issues as well. They're very much relevant to the physical health problem as well. The non-attendance, the non-interest in that, and why and how and what extent the person is willing to deal with at a particular point in time, often a source of great conflict between parents and young people. Liz, do you want to comment? Because I think it's one of the ones we argue with parents at the most. Yeah. Parents are really fussed. They've suddenly got to create the social containment around alcohol and drug use that the rest of the society appears not to care about.
I think these are extremely difficult issues, but it is, you know, we have tended to segregate drug and alcohol and psychiatric issues in psychiatry to the detriment, I think, of patients. So making sure everybody has a safety plan, that they have an alcohol and drug management plan as well. And that is monitored, and that people require the skills either through motivational interviewing or through tracking or through cognitive therapies, looking at other coping skills to make sure that that is continuously tracked and managed during the course of treatment. And we tend to have a bit of a nihilistic view, I think, about dealing with drug and alcohol problems in young people, but actually if you actually treat it very assertively and consistently, you do get very good outcomes, particularly when people are, you know, recovering from the illness that they have and have the capacity to be able to manage that as well.
So one of the other complex areas here, you know, we're trying to avoid the illness type thing, but the one I hate the most, drug-induced psychosis. So if he just stopped taking the drugs, he wouldn't be psychotic. As if there's this simple one-way relationship, and as if that's kind of some simple thing to say. When often the relationship between other drug use, particularly cannabis use and stimulant use in these situations, is actually complex. And the great majority of people that have psychotic syndromes and other syndromes and mood syndromes who are taking those drugs concurrently do not simply have a drug-induced thing, and if it's simple causation, it caused it. And if they stopped it, nothing would go wrong. Or everything would be back to normal, nothing to see here, and that's all that needs to happen. The parent or somebody else just needs to stop them taking the drug and the problem's gone. Often the quickest way to be kicked out of a public hospital or other setting is to say, drug-induced psychosis, no help, no treatment. As distinct from what's the underlying vulnerability, the relationship with the comorbidity, and the bi-directional nature of that is complex as to how people are using different drugs and the symptomatic relief that they provide, or the pleasure that they derive, or what other factors, the social environment in which they're ensconced, you know, in those particular areas, which promotes drug use and is complex, it's complicated, needs to be addressed. So talk about issues we don't really listen to because we just go, oh, good. Can we hand pass that one on to some drug and alcohol specialist? Or, you know, if only the family would behave better, or if only they'd lock the kid away in some part of society that doesn't alcohol or drug use, or, you know, change schools or something, it'll go away. Made worse often by the treatment system saying, yes, if you make that go away, that kid will be perfectly well, which is almost never true. The situation is always more complicated than that. In the last seminar, we dealt quite a lot with the issues of physical health, about assessment. Really challenging for us is get on and treat it. So in particular situations for everybody, in terms of weight control, in terms of monitoring, in terms of dealing with body image related issues, but then the detection of particular metabolic dysfunction, of immune dysfunction, of hormonal dysfunction, and then the consideration of what things might actually be useful. What sets of treatments are we going to address? What's interesting to me is we end up discussing many of those with families who've read all about them, only to find their psychiatrist has never read about them. Is that newfangled immune stuff? What is that fish oil stuff? Minocycline, never heard of it. Metformin, isn't that for diabetes? What do we do? You know, a lot of these areas in which actually better informed patients and their families actually have a lot of ideas and want to hear what you know, which is, of course, the key question, is it right for you? There's a lot of discussion about early intervention in physical health, and as remarked on last time, most of our intervention for young people is late. After we've started them on medication, after they're stage 2 or beyond, after they've gained weight, after they're in trouble, then people say, well, you should eat less and you should exercise more and maybe you should stop the medication you were on because maybe that caused it. So Liz, how do you feel about when you inherit the, they should now lose weight, start exercising more, and preferably stop the medication that was helping?
Yeah, too late. Missed the boat. Completely agree. By that time, it is too late. And as we think about these things really early on in the course of illness, and if you're starting medications, and sometimes you have to, which we know are going to affect people's weight, like starting young people on clozapine, for instance. We've just done that this morning in our clinic.
Or any antipsychotic.
Or any antipsychotic.
Or any antidepressant, potentially.
Yeah, but some are worse than others. Then it is about making sure that that is assertive management. And I know we know that. We know that there is monitoring in place, but I don't think we know really how to do it.
So which physician is doing it?
Standard practice.
Which physician is doing it?
Well, I am still an outlier in my pathology in terms of monitoring people's metabolic status. So obviously not enough. Otherwise I wouldn't be an outlier.
Because the other standard hand pass here is, oh, I sent that off to the GP, or it's being followed up by a nurse somewhere, or I'm going to refer them to 4 other clinics, the metabolic clinic, the endocrine clinic, the something else clinic, and the patient and the family's going to go there and they get a chart. You should lose weight. You should eat less. And maybe you should stop the medication the psychiatrist put you on. You go, this is not helpful. What are the real options? What is the real consideration here? And what other things do we need to think about? We're involved in very much in trying to assess, who should go on to metformin at the point that they go on to other sets of, what sorts of tracking mechanisms, in discussing last time in terms of insulin and homeostatic modulation of insulin, those kind of issues that we are in the metabolic states. What is being done to track this, and are you tracking it? I was told recently by a young psychiatrist, I don't do physical health. I don't physically examine anybody. I don't do body measurements. There's something that's for the nurse to do, or what nurse? Or we don't have one. Who does it? We don't do it. We just do mental health. I'm afraid there is no mental health separate from all that. And just like many other areas of medicine, if we don't do it, nobody does it, which is not okay. On to the next slide. Okay, now we come to the box. Of the boxes that we've got 3 boxes or trajectories that we are really interested in. The neurodevelopmental, the kids who grow up, often had learning difficulties, they've often got evidence of autism spectrum or ADHD as kids, they've clearly had a brain developmental path, often then that hit puberty and became really difficult in particular areas, that suggests that they have particular challenges. And don't forget, if they're on their autistic or those other paths and they hit puberty and then they hit social development as a teenager, the social challenges go up. So those who don't have social skills, those who have trouble interpreting the emotional environment, those who are having trouble in those particular areas, those who've got sleep-wake cycle disturbances, they need particular sets of issues. So in the first line areas, and in all these areas at earlier stages, when things are less severe, we tend to put an emphasis on those particular issues. Now, in that area of the neurodevelopmental, rather than having a very strong cognitive emphasis, it has a very strong learn the skills, learn what to do, learn how to read and understand particular sets of issues, make sure the educational environment is really appropriate on an ongoing particular process. In relation to that, specific cognitive training and particular IPS or individual placement support models in education and employment can be particularly important from a psychological and social point of view. From a pharmacological point of view, there are the issues of which antipsychotics, plus or minus fish oils, a controversial and interesting kind of area, but an area which continues to be explored in the early intervention psychosis area in particular, as to its relative merit or not, that need to be kind of looked at. Liz, right off the bat, if you go for the antipsychotic script pad,
yep.
What do you go for?
I mean, very much it is driven by the symptoms that the person has, but if you're going to try and reduce metabolic pressure and to try and manage kind of secondary kind of metabolic issues, then aripiprazole, those antipsychotics that are less like
metabolically
insulin resistant.
Yeah.
So aripiprazole and lorazepam are 2 that we currently favour.
But there are complexities here. When people are really agitated, when they're really distressed, when they really can't sleep and whatever else, you're going to have to necessarily look at other options. And that may include quetiapine, in certain situations it may include olanzapine. Certainly very challenging from a metabolic point of view. As you said earlier on, we may get to the situation of actually using clozapine earlier rather than not if the psychotic syndrome is way out of control. But we're going to monitor it. We're not just going to start it and walk away or inherit people from hospital who come on large doses of olanzapine or quetiapine on an ongoing basis, and we just have to cope.
Well,
Bad idea.
we often see the ones who've been put on olanzapine and gained 30 kilos and say, I'm never taking that.
And then told to stop eating. You know, can you fix me now, 30 kilos later? And I think if those of us who are around, I hate to say it, we're around, and this is a study we were involved in more than 20 years ago, olanzapine versus risperidone. I must say, we were measuring people's weight over the first 10 weeks of initiation of one versus the other. I must say, I was personally shocked at just how quickly people could gain weight in the first 10 weeks of actual treatment, and relatively insensitive to their perceived thing. Needless to say, Liz and the young women she sees are not sensitive, not insensitive, extremely sensitive. 1 or 2 kilos gained is enough that they may go in there again. Yeah. And not only that, their relationship to medications in general, not necessarily just that medication, medications in general is gone. Okay, so that's the neurodevelopmental psychosis trajectory. The hyperarousal anxious one's the common one. Anxious kids become anxious depressed teenagers, become anxious depressed substance abusing adults. Clearly, right up front here, really good cognitive behavioural therapies, really good psychological therapies, and more skilled psychological therapies are important. Those that are now increasingly able to be done online in particular ways that really respond to the arousal, to the environment, to understand the internal cognitions, to actually be in control, understanding the cognitive and behavioural elements, cognitive and behavioural elements that are open in those particular areas, because the behavioural elements in terms of exposure for those with social anxiety and for avoidant behaviour is really important with teenagers, because the boys do get anxious, and our favourite substance is alcohol or cannabis for actually dealing with that anxiety. So very quickly in boys in particular, that gets complicated by substance misuse. So really skilled, not unskilled, properly skilled, not just chat, not just case management, not just social support, but actually skilled cognitive and behavioural therapies in this area. And it's really interesting the extent to which many young people never get. They've seen people forever, but they've never had anything approaching a standardised cognitive behavioural therapy or interpersonal therapy or one of the others, metacognitive therapies, that is actually relevant to these areas, or an appropriate exposure-based treatment for their social anxiety or their OCD, or for other areas where avoidance is a large area. Clearly, from a medication point of view, the selective serotonin reuptake inhibitors, the common ones in Australia, particularly sertraline and escitalopram or fluoxetine for younger people, work really well for anxiety. Just recently, I was challenged yet again, don't they cause people to commit suicide? Well, the issue about monitoring anyone who starts in this situation in terms of agitation on particular issues. So Liz, do you want to comment on actually, even though they're common, the monitoring in the first few weeks of prescribing an SSRI or an SNRI if you go one step further and go to venlafaxine or to duloxetine?
So obviously having a kind of standard practice around that, which is to be very explicit about the side effects that people can experience, particularly sleep disturbance or nausea, but also if there is a degree of agitation. And to be very clear about what to do if that eventuates. Starting on half a dose, I think, is important. So starting on low doses, particularly when in younger people. As people get older, it's easier to start on kind of higher doses, but for young people, because their response to antidepressants can be atypical, it's important to start at low dose and monitor that over the first 4 weeks of treatment. That doesn't mean you need to speak to them every day or see them every day, but to have some system where they can actually report back to you and you can review the response to treatment. And if they do get agitated or distressed or have more suicidal thoughts, which happens rarely but can happen, then what is the action that person should take?
Yeah. So most of the work we've been associated with in teenagers and in adults, that issue of at least agitation and sleep disturbance is not uncommon. So and the 5 to 10% where it's severe, people aren't warned in advance. It's problematic. Of course, we can't know things in advance. We look at our staging model, our progression. One of the common progressions is from the hyperarousal group through the next group, to the circadian bipolar group. And that is often, sadly, only revealed on exposure to, in our world, things like SSRIs or SNRIs, or in the person's own world, to the use of stimulants, or to other things in the wider world, like change of seasons or other factors. That essentially circadian or bipolar-like thing may well be revealed, sometimes in relation to something we've prescribed, or in fact, some other things in the environment or things that people have taken themselves. So got to accept in this area that that risk in young people is significant, it's explained, it's known, and actually it's monitored for. If that happens, it may actually take us into the next category, which is really the circadian bipolar group. Now, we don't want to do that randomly. We hope to identify that through recognising the kind of phenotypes that are associated with that in the first group, which we discussed previously, the sort of delayed sleep syndromes, the fatigue during the day, potentially family history of bipolar disorder, strong seasonal kind of illness and changes in behaviour that might give you some signal that the person is more in that group, the more the kind of jet lag type group than the anxious, preoccupied, obsessional type person who's in the hyperarousal type group. In that group, the cognitive behavioural therapy has a different focus. It's on behaviourism, it's on regulating sleep-wake cycles, it's exposure to morning sun, it's about behaviour activities, it's about good information in that area. Not rubbish, not just sleep hygiene, a term I hate with a passion, as if it's about sort of washing your hands more and somehow your sleep will be better. It's not just about going to bed, it's about what you do all day and light exposure and activity to drive the repetitive nature of a more stable sleep-wake cycle system. In that particular area, getting into more specific psychological treatments, the use of light therapies, of various things to manipulate sleep therapies may be required in the more severe cases. Pharmacologically, it's where we have become quite divergent, I think, from conventional practice. We try not to just chuck SSRIs into that group, because really, this in particular the bipolar depression area remains one of the most controversial in psychiatry, since there's no agreed first-line treatment. And a great division ongoing between North America and Europe as to whether antidepressants are good or bad. Do they make the situation actually worse by making it more unstable, but someone's terribly depressed, they're going to do nothing? We have increasingly got into more of the melatonin-based kind of melatonin itself, or melatonin analogues in that situation, melatonin-based antidepressants, and then into the really tricky area of use of mood stabilizers. When to initiate lithium, the use of things like pregabalin and lamotrigine, and of other waking agents like modafinil. Complicated territories needing really good explanations, really good characterizations, and one that we don't rush into without complex monitoring through things like Fitbit type devices, activity devices, things you wear around your wrist that tell you where your sleep-wake cycle is, and close monitoring of that situation. So Liz, in that tricky situation,
yes,
what takes you down that path?
So in terms
before the person has the frank manic episode, then you go, oh, that's what it was.
So I think recognition of those young people who have more atypical type features to so what we call atypical depression, which as Ian has described, are the changes in sleep-wake cycle and fatigue.
And weight gain.
And weight gain. So overeating or comfort eating. So if you think about bipolar type syndromes, these circadian syndromes has been related to hibernation and migration. What you see in young people are the hibernation syndromes, the ones where they don't want to socialize, they're often socially anxious or irritable. They want to hibernate, they want to sleep all day, they want to stay under the covers, they overeat rather than undereat, and they don't respond to SSRIs, they don't respond to
which may make them worse.
Which may make them worse, may make them kind of more irritable, agitated, or precipitate these kind of episodes of kind of hyperactivity with self-harm, kind of agitation that don't necessarily look like typical hypomania. They just kind of agitated, excited.
And didn't Joss make that conscious, despite the fact, and he developed a frank manic syndrome, they had that. In all the discussions they had about his bipolar disorder with other people, there was no emphasis on regulating his sleep-wake cycle. Now, when I was really, really young, and that was a really long time ago, the one thing we did in hospitals for people with manic syndromes was make sure they went to sleep at night. To actually make sure, and then not so good, but we should have done more of it, got them out of bed during the day to restore their sleep-wake cycle. So one of the most therapeutic things you can do in those syndromes is restore some 24-hour regularity, whether you're doing that in hospital or you're trying to do that at home. And lithium being the standout agent here, of course, the controversial about where you introduce lithium, generally speaking, blind Freddie can do it after the first manic episode. Prior to that, controversial as to where we go and requiring more evaluation. Using lamotrigine, a very interesting kind of issue. Pregabalin, being controversial in this area because it's associated with weight gain, but then again, it relieves the agitation. I'd say the other issue about this issue in this area is differentiating agitation from anxiety. Just to use slightly different words, I'd say this area, the depression in this area is characterized not just by fatigue, but by periodic agitation.
Yeah.
Psychotic-like driven behavior that has no easy explanation. Quite different to anxiety in the hyperarousal group, where people can tell you the cognitions that are driving them crazy.
Yes.
In a particular way. Where the agitated person can't tell you, but they're moving, they're agitated, and they're quite suicidal and unpredictable in those particular issues. And so I think the response to the agitation is something that's very missed by clinicians who are not very familiar with that particular issue. But probably from our point of view, one of the clues to get on in that particular area. And of course, in that particular area, when severe, and not mentioned here, is the concurrent use of antipsychotics and potentially the use of more sedating antipsychotics, whether that's quetiapine or olanzapine in certain areas, may need to be considered as part of the combination. Okay, if we go to the next slide.
Initially, I was never asked about what my goals in my mental health and well-being journey were. However, now I am asked. I'm asked at every check-in, and it makes the world of difference in how I am feeling and how I progress.
Go to the next slide. So that issue of, in the wider consumer world for sort of middle-aged consumers, the whole recovery type notion. In the youth world, it's got to be about what's the goals. And so in our kind of complicated, all the things we're trying to track over time, and you really need some sort of technological database to make sure you're doing this effectively as you do it, up the top in green, separated out, for most of the young people we're talking about, it's getting back on their developmental path. It's getting back to school. Josh wanted to go to university. Sam wanted to get on with his particular life. Jess wanted to get out in the world in a particular kind of way. Social and occupational functioning doesn't really kind of capture, really, the richness of that and what Aboriginal people would call social and emotional well-being in a more particular way. That goal of being functional and participating in life, so often ignored while people are putting people in a box in a particular kind of area. We can't ignore the box. That is the clinical course. That are the illnesses that we're actually dealing with. We're actually looking, though, concurrently at each of those particular factors and the extent to which they drive each other differentially over time. The extent to which physical health problems impact on social and occupational functioning. The extent to which concurrent alcohol and drug use impacts on suicidality over time. The extent to which suicidality creates additional physical harm over time. The extent to which our treatments for particular illnesses give rise to other physical health problems. Unless you've got a more complicated framework in your head, you're not really going to respond to what Sam was saying. It's about me, it's about the holistic issue, it's about what's to become. So Liz, is it really so hard to have those concepts in your head?
I haven't been doing this for a while, no, but I think teaching other people, so I train registrars, and a lot of the registrars who come say, I've never actually thought about this in
I've
this
never
way.
thought about it as a person.
So the way they formulate people is according to the
Biopsychosocial model.
but not actually according to the kind of syndrome that people present with and the factors that are actually really important to people. So in terms of their social and occupational function and their physical health. So I think we really need to rethink the way that we formulate, because that is what drives treatment. So I think it is not difficult, but it does require a different frame of thinking.
And there is, sitting behind this, for each of the people we're talking about, like where they are in development, there is a whole developmental thing. So Beth is 13, just coming into adolescence in a particular way, having been a very successful kid before puberty, in primary school, but now really complicated in early puberty. You know, Joshua, who was assisting really at the end of his school period and transition to university, and suddenly things fall apart. Really different developmental kind of challenges. The boys we see around 15, 16 who are trying to operate outside their family for the first time in social settings that are really difficult. And of course, seeing that from a brain development and social challenge point of view, quite different. So we're actually operating across a very complex developmental spectrum where different things are happening with families and others on an ongoing basis in the social world in which they're operating. So that social and occupational functioning, the developmentally relevant tasks and the transitions that people are at in that always need being taken into account. Next slide. Right, so there are many things that run across all of the areas that we're talking about in terms of things that we need to be focusing on. There are many cognitive issues that really do not respect the box. We're trying to say they're not diagnostically specific. Having cognitive attention, very few people have ever learned cognitive skills. For all the public health we teach about sex education and drug education and everything else in schools, it'd be really nice if everyone had done a bit of cognitive therapy and a bit of other kind of issues about controlling your own thinking, your own anxiety. So often at this stage, a lot of problem solving. When Liz and I used to run training for doctors, the most popular thing was to teach them problem solving, which they then taught their staff. You know, it's really, many people don't really options for solving problems and how to take actions, the importance of that. In a lot of the work we're doing on about the secondary prevention, clearly attending to physical activity cycles, not just telling people to eat less once they're 30 kilograms overweight. You know, actually the concurrent for the people we're dealing with in a society that uses a lot of alcohol and other substances, that has to be kind of closely looked at. And the issues around education and vocational support, and not just simply applying for jobs, the extent to which you may require programs that work, like individual placement and support, needing to be negotiated, run across many of the areas we're talking about. So they apply more or less to everybody, in addition to the specific treatments that we were just discussing on the previous slide. Now, it doesn't mean you're doing it all individually. It means, of course, teams of people working together with those different skill sets. Next slide. Nope. Right. Just to say on the social and occupational functioning, there are many, many factors feeding in from the trajectories we've talked about. But just to emphasise, there are many things that one can do about social and occupational functioning just to look at directly, whether it's in the education environment, whether it's in the employment environment, using other particular issues. So while we, in very complicated academic circles, try and work out the extent to which all those things down the bottom there contribute some proportion of the variance in some particular way, actually, the rest of the time we should be looking at things that just work to support people be in school, post-school education or work. Mind you, right across the bottom, we have a wide range of interventions available. We can't all do them all, but working with people who do those things well, really important. For example, just to pick one, exposure therapy done really well. When I was really, really young, hospitals and outpatient clinics used to have nurses and other people who did exposure therapy with people. Rare these days in a very cognitive world that actually people actually do exposure therapy. But for a lot of social anxiety and for a lot of other factors, it's critical to what actually we need to do. Similarly, in some of the other areas of actually making sure that people have safety plans is critical to what we do on an ongoing basis. Next slide.
Receiving the right care enabled me to enter into tertiary education and to provide more career options going forward.
Next slide. So we often say, look, you don't get well to go to work or school. You go to work or school to get well. I mean, the other issue about supporting people about social and occupational functioning, whatever else we do, being back in those environments puts structure, it puts sleep-work cycles, it puts social interaction, which then contributes to recovery from the syndrome. So it isn't all treat the syndrome to get well and resume functioning. Sometimes you've got to restore function to allow people to be well. So in summary, we try to use 3 elements to guide our treatment selection. The multidimensional assessment, trying to understand the scope of the problem, listening to the whole story. Clinical staging, what stage is the person at, for the size of the ladder and the nature of the ladder to get out of the hole, and then the secondary prevention that follows. For the third place there is, well, actually, what trajectory are people on an ongoing basis? To actually try and choose that which is most relevant, that you've seen across development, most consistent with their childhood risk and most consistent with where they're going in terms of the likely illness trajectory, at whatever age they find themselves. We don't go for the simple binaries that so is loved by certain professors of psychiatry. You have this or that. You must have the arousal or the circadian. You must have the developmental psychotic or the circadian. You can't, it's more likely, and in many of the people we see with early onset with complex families and complex genetics and complex environments, it's likely that you have more than one. And you may need to work through with people which in their individual situation is most relevant, but also in terms of treatments, which of the treatments available in those areas is most particular to the particular person. I think just knowing that and stating that in advance makes it much simpler. Liz, are there any final comments you'd like to add?
No, I'd just like to encourage people to think about the box that they're operating within and to try and expand it, and that it is extremely rewarding. Not only is it rewarding, it produces better outcomes for young people and their families.
Next slide. So we hope you'll join us again for the 5th in this series, which is actually going from the individual person to actually service models. It's very hard to do this all on your own if you're not working within a service that actually tries to do this. So on Thursday, we'll return to that particular kind of issue. You can follow the video recordings of each of these sessions, which we upload progressively after a little bit of editing to YouTube on an ongoing basis, so that you can follow the whole particular series. You can get CPD points for those who are relevant. We're very grateful to our supporters. You can get the details of the Medical Journal of Australia supplement. If you write to us, we'll provide that with you, and also the links to our other Cambridge University books and other resources. And this work would not be possible without the support, philanthropic support of Future Generation Global, their investment people who've invested in the future of young Australians and support us in this education and training, and the families of people who've been looked after by Liz, who are trying to make sure that not just their kids, but many, many more kids can actually get the right care the first time. Thanks for your attention.